Good morning, everyone, and thank you so much for joining us. I am Kimberly Robinson, Vice President of State Government Affairs, and it's my pleasure to welcome you all today to this discussion on how Medicaid can address social drivers of health. As we know, one health outcomes are not simply based on what happens in a hospital or a doctor's office. In fact, it's well documented that about 80% of one's health is determined by non medical factors, such as access to nutritious food, stable and affordable housing, employment, and transportation, which are known as social drivers of health. Medicaid, which is jointly funded by the states and the federal government, provides health coverage to roughly 80 million low income individuals in our nation. And these individuals are often from historically marginalized populations that have a diverse range of health related social needs. Medicaid has been and continues to be at the forefront of addressing these social needs, working to bridge gaps in care and improve outcomes for millions of Americans. Today, CareFirst is thrilled to host this panel of Medicaid experts who will explore Medicaid's roles in tackling these needs and share insights and proven strategies that have positively impacted communities across the country. Whether you are a policy expert or someone just simply committed to making healthcare more equitable for all, we hope that you will find a benefit in what will be a fruitful conversation. And with that, it's my pleasure to introduce our moderator, CareFirst Community Health Plan's Chief of External Operations, Sheila Yayazadeh. Sheila?
Thanks so much, Kimberly. I am absolutely honored to be leading this dialogue today. Since Medicaid's creation in 1965, the program has evolved to meet the changing needs of now 80 million low-income Americans. Over the past decade or so, interest in addressing health-related social needs has grown exponentially, and for a very good reason, because as Kimberly noted, the social drivers of health are vastly interconnected. If someone does not have access to transportation, they will not be able to make it to their healthcare appointments. If someone does not have access to nutritious food, it will be that much more difficult to prevent or manage chronic illnesses. To effectively meet the health needs of Medicaid enrollees, it is critical to look at the broader factors each enrollee may encounter that prevents them from living their healthiest lives. During the Biden administration, the Centers for Medicare and Medicaid Services expanded opportunities for Medicaid agencies to address health-related social needs, ranging from state-level 115 demonstration waivers and flexibilities to Medicaid managed care efforts, such as in lieu of services and others. Even as we look toward a new administration in January, Medicaid is likely to continue to play an important role in helping to meet the unmet social needs of its members. CareFirst proudly serves over 94,000 members through our Medicaid managed care plan, CareFirst Community Health Plan in Maryland. And we as an organization are deeply committed to serving the diverse needs of our members. As CHPMD's Chief External Operations Officer, I have the privilege of interfacing with external partners and building our strategy to ensure we are meeting the needs of our members. Before we jump into the panel, I want to mention that while health programs like Medicaid play a critical role in addressing health-related social needs, they are not intended to replace efforts by other federal, state, and local social service programs that address these social needs. Instead, Medicaid complements these efforts to provide comprehensive whole-person care to enrollees. Now that we've provided a bit of background to prime the conversation, I would like to call on each of our panelists and have them tell you a little bit about themselves. They are leading experts in Medicaid, so we're very lucky to have them with us today to share their insights on how Medicaid can address social drivers of health for its members. Without further ado, I will start with Matt Salo. Matt, if you can come off of mute and on video. He is the former executive director for the National Association of Medicaid Directors and the founder and CEO of Salo Health Strategies. Matt, would you like to say a little bit more about yourself?
Great. Thank you so much, Sheila. And thanks to CareFirst for hosting this. It's always a pleasure to come and talk to everybody and to be on an august panel with Rodney and Jamie as well. So I have spent essentially my entire career, about 30 years now, in the state Medicaid space. Almost all of that in some form or fashion in bipartisan associations of state government officials who care about Medicaid. And that includes, as you mentioned, I had the privilege of founding and then running the National Association of Medicaid Directors for about 11 years. Prior to that, I spent about 12 years at the National Governors Association, um, dealing with their health and human services reform agendas, 90% of which was Medicaid because it's a pretty important program. But also 5 years working on Medicaid policy before that with the American Public Human Services Association. And I would just sort of note that, even back then, so when I got started in 1994 and I was working on a different kind of waiver, the 1915C home and community-based services waivers, that was actually one of the earliest incarnations of thinking about social drivers of health, where, for people at risk of institutionalization in a nursing home or other facility, Medicaid found lots of different ways to provide home delivered meals, to provide environmental modifications to your home, and to provide other types of, supported employment and other services, very much outside of the traditional realm of medical care. And the great success of that in terms of keeping frail seniors or people with physical, intellectual, and developmental disabilities, in their homes and in their communities, really laid the groundwork for a lot of thinking that, wow, might this not help different populations, a more general public who are struggling with those. And so it's always exciting to be a part of this, and look forward to the conversation.
Yeah, likewise. Can't wait to get into it. Next up is Jamie Snyder, the former director of the Arizona Health Cost Containment System and currently the Chief Executive Officer and President for JSN Strategies, LLC. Jamie?
Good morning, Sheila. It's such a pleasure to be here and to serve on this panel with Matt and Rodney, two close colleagues. Like Matt, I've worked in Medicaid for most of my career, served as the director of the Medicaid program in Texas as well as Arizona, and had the opportunity to serve as president of the board for the National Association of Medicaid Directors under Matt's leadership. I now serve on the Medicaid and CHIP Payment and Access Commission, so stay closely tied to discussions around federal level policy pertaining to Medicaid. With this discussion, I'm really excited to participate today because one of my kind of hallmark achievements during my tenure as Arizona Medicaid Director was to usher through the approval of an 1115 waiver, allowing the state to cover the cost of temporary housing for individuals leaving institutional placements. So really excited to have this discussion today and talk about what states are doing around the country.
Wonderful. We can't wait to hear your perspective as well. And of course, last but not least, we have Ronnie Whitlock, who is the former health policy advisor on the Senate Finance Committee Republican staff and currently a vice president at McDermott and Consulting. Rodney?
Thank you. I am Rodney Whitlock. I am Matt's younger, more attractive doppelganger. And I'm older than you, so I get to make that joke. So I did 21 years on the Hill, 10 in the House, 11 in the Senate, including that stretch with the Finance Committee, working a lot of things Medicaid on the outside. I've done so similarly in the consulting space. And my perspective is one of someone who eats, lives, breathes Capitol Hill and how the legislative process works, which sets up what can occur in the regulatory process very often. So that's the perspective I'll bring to the table and look forward to chatting with my colleagues.
Fantastic. And so we're going to get into it a little bit now. Love the different perspectives that we have on here. In recent years, the Centers for Medicare and Medicaid Services, CMS, released a number of flexibilities to address health-related social needs, including the Section 1115 waivers, which have given states the opportunity to add benefits such as short-term housing and nutrition supports, some of which you all have mentioned in the past. In what ways have you seen Medicaid programs leverage federal and state policy flexibilities to address these health-related social needs? And do you see the role of those Section 1115 waivers and other flexibilities changing in the coming years as we think about new administration? Jamie, as a former Medicaid director, I'd like to start with you, and then we can kind of pass it around.
Sure. No, I'm happy to kick us off in terms of our discussion around social determinants of health. I think it's important to kind of reflect back on what Matt said earlier. The work around social determinants of health and health-related social needs has been going on in the Medicaid space for a long, long time, in formal and informal ways. States more recently have really started to take advantage of some federal and state kind of policy levers to advance work in the health-related social needs space. The most notable of which is really 1115 waivers, right? We've seen a number of approvals. I think there are 19 states now that have approvals to cover temporary housing. I think there are 10 states that have approvals to cover nutritional supports under an 1115 authority. But 1915 authorities, as Matt mentioned, have been used for many, many years to advance this type of work. And there are other opportunities for states outside of waiver approvals, which are important, but take a long time, right? There's a whole process of obtaining community input, going through a financing exercise that can really delay the implementation of some of these really important benefits. So it's really important to kind of think about some of the other opportunities that states have. One of the most notable of which is in lieu of services. And so CMS offered some guidance, I think, early in 2023, making sure that states knew that under their state plan, they could extend in lieu of services that are available in settings that are available currently within their Medicaid program. So a bunch of states has started to move in that direction outside of having to obtain some sort of more extensive waiver approval from CMS. Also, there are other levers that states can employ on their own, ensuring or requiring that managed care organizations are offering value-added services. And I know in both Texas and Arizona, where I worked, that was an important lever that we employed and that the plans really used, managed care organizations really used to look at health-related social needs and social determinants of health, really looking at nutritional supports, housing, and leveraging the expectation around value-added services in that regard. A number of states, too, now have community reinvestment expectations, requiring that managed care organizations reinvest a portion of their profits back out into the community. Again, that's another important lever that states can employ and managed care organizations can employ to advance these services to their membership. And then the last thing I would really say is just it's important to look at partnerships between Medicaid programs and obvious partners that they would work with, but also between managed care organizations and community-based organizations. I know in Arizona, we leveraged our health information exchange to stand up a closed-loop referral system. In Texas, the Episcopal Health Foundation is doing some really formative work around health-related social needs, partnering very closely with health plans throughout the state of Texas, including BCBS Texas, to ensure that members are, that we're eliminating barriers to these really basic social service needs so that they can access needed clinical care. So a lot of opportunities available, some more formal, some less so, but all important in ensuring that we're enabling members to obtain the benefits that are so critical to ultimately accessing clinical care.
Thank you for that. I mean, a lot to unpack on that one. I'm curious, and for Rodney or Matt, do you see a shift from the waivers more to expectations on MCOs with value-added benefits, or more programs that incorporate community partners and the other and such?
Yeah, so I'll chime in, and I'd love Rodney's thoughts on this as well. I think the way I would frame it is, thinking about how we got here is a combination of, number one, just everyone acknowledging that if we don't pay attention to these upstream challenges, Medicaid is going to have to deal with the downstream, increased mortality, increased health risk, increased costs. And that trying to address these things as early as possible is good for the patient, it's good for the system. And that Medicaid as a tool, the combination of the state and the federal governments and the match rates and the flexibility inherent in the system, combined with the fact that, and again, I've worked for state governments for many, many years, they are problem solvers. And when there is an issue that they see a need of their citizens and a tool that they can use to fix it, they're going to lean into it. And that's how we see Medicaid grow, and that's how we see Medicaid lean into a lot of the SDOH services. But I do think that there's, the dynamic is how much of that is sustainable on the trajectory that it's on. How much can Medicaid continue to drive these costs as opposed to thinking about the partnerships, as Jamie talked about, partnerships with the MCOs, partnerships with the CBOs, partnerships with other federal entities, local entities, everybody in between. Medicaid is an important driver and leader, but it really needs kind of an all hands on deck approach to this. And that's going to take, leadership at other levels, not just in Medicaid, to be able to bring those complementary sets of services and attention to this problem.
So yep. I'll jump in, and the role I think I'm going to end up playing here for the next 45 minutes or so is, elections have consequences, and the people taking roles both in the legislative branch and the executive branch, they're focused on the United States being $36 trillion in debt. And they're going to look at Medicaid and go, outflows need to be justified, and certainly additional outflows need to be incredibly justifiable. And so that's going to be the tension here, is making the case that this is creating a more efficient way of government working. Did you hear what I did there? Hinting. You better be able to explain that if people are looking at government efficiency.
And I'll just chime in.
Go ahead, Jamie.
Sorry, I'll just chime in really quickly. I think it's going to become more important than ever that states demonstrate the real return on investment for this work, right? So they have to be able to demonstrate with data that when you house someone for 6 months or longer, you see tangible improved health outcomes and you see savings. That's something that I know in Arizona, because we've been doing some housing work for many years with state funds, we were able to demonstrate to our governor when we approached him about our 1115 waiver idea that was really compelling. But that kind of data is going to be critical if state programs and managed care organizations want to continue to do this work.
Yeah, and I think representative of some of the policies we updated regs we saw come out regarding in lieu of services and reporting requirements, and a lot of those parameters that have been put in place to help manage the outcome and understand the cost effectiveness of those programs, which segues nicely into the next question, where we know Medicaid accounts for almost 1/5 of healthcare spending. And to your point, Rodney, with the change in administration, we are going to be looking at that with a bit more scrutiny. It represents a large portion of each state's budget, right? And given the budget challenges that many states are facing today, how can states balance that initial investment required to address health-related social needs and that potential cost savings? Matt, I'm going to turn it over to you.
Yeah, well, I would first answer that in reflecting on Rodney's kind of touchstone point, which is, Medicaid is a state-federal partnership. It is also a public-private partnership, but the financing is a state-federal partnership. And so the lead that we're going to take, we, the states, from the federal government is going to be really, really important. And so if there is going to be, fiscal pressure to reduce, whether it's $350 billion or it's $1 trillion or whatever it is from federal expenditures in Medicaid, that is going to make it more difficult for states to figure out how to make those investments or those increased investments. And to getting to Jamie's point, I kind of think about it as sort of like a series of concentric circles. And at the very core, if you think about, individuals who are homeless, who are struggling with mental health and substance abuse issues, if you can provide supportive housing to them, you can clearly and immediately see a healthcare outcome and a fiscal ROI. And that's obvious. And it's like, this is a no-brainer. But the more you expand out into additional types of services for additional populations, the harder it becomes to show real return on those investments in narrow windows. And part of the challenge for state governments is that Medicaid tends to run on an annual or a biennial budget. Now, if you're doing an 1115 waiver, maybe you have the flexibility or the opportunity to think about it in a 5-year window. But even so, sometimes those windows aren't long enough to be able to truly capture what we think those ROIs are. And in a time of increased budget pressure, whether that's coming from the federal government or, Sheila, to your point, that we're seeing state budgets independent of that, being restricted, being constrained, and being in real trouble compared to the last decade or so. There may be additional pressure on the states to say, well, maybe we need to do less. Maybe we need to find other people who can come to the table to do more. And whether that's the MCOs, the CBOs, other federal agencies, or who knows, that will be the pressure.
Yeah, I think we've talked a lot about some of those flexibilities in some of those programs, Jamie, you had mentioned earlier. I think kind of shifting from this conversation around state budgets and sort of looking into different opportunities and partnerships, how can states and the federal government partner even more effectively with the MCOs to address health-related social needs? We know that Medicaid is, managed care is serving roughly 74% of all Medicaid enrollees. Rodney, I'm curious to get from your perspective, how do you see the states and federal government partnering together with MCOs?
So that's sort of a fascinating dynamic to watch, particularly over the next 4 years, which if managed care is effectively working under per member per month, and Congress and the administration wants to push Medicaid more in the direction of per member per month, or maybe worded differently, per capita payments, these seem to flow together, don't they now? And it raises questions if, hey, here's a payment, produce the outcome, good luck. And you could see Congress heading in that direction. And Medicaid managed care plans for many years have been in that per member per month situation where they have to then meet certain expectations of what they're doing for that and produce outcomes to a degree. There's a potential flow there that could work together. Now, under what financial terms, that's a much bigger conversation.
Yeah. Jamie, anything that you'd like to add to that one?
Yeah, I think just kind of going back to what we've talked about already, I just think it's going to be more important than ever that we look to some of those other levers as opportunities to advance our work in the health-related social needs space. Matt captured it perfectly. States are problem solvers. They're going to figure out a way to handle these upstream problems and issues that ultimately impact health outcomes, even if it's not through a formal like 1115 or 1915 authority. And so looking at value-added services as an option, looking at in lieu of services as an option, looking at requirements around community reinvestment activities. And I know we're going to get into this in a moment, but managed care organizations have been a tremendous partner for states historically, long before we started talking about the 1115 as a vehicle for social health-related social needs. And so I think it's really kind of going back to the drawing board, looking at what managed care organizations in partnership with states have done to partner with food banks, to partner with community gardens, to develop formal relationships with community-based organizations and think about value-based arrangements with clinical providers that engage community-based organizations. Those are some of the opportunities that we've explored historically that managed care organizations have been, really leading the way on for many, many years. And so really thinking about those opportunities, and again, focusing on, while we're doing that work, on really developing the use case and looking at the data in terms of what that return on investment really looks like from not only an improved health outcome standpoint, but from a savings standpoint, when you're able to address those barriers to care early on so that individuals can access appropriate preventive care rather than going to the emergency department or urgent care for their basic healthcare needs.
Yeah, and I could say for CareFirst Community Health Plan Maryland, we are certainly looking at those value-added benefits as a way of meeting some of the needs that we see in our population, right? Whether it be transportation or maternal food benefits. we also keep in mind that we are financial stewards of the state's dollars and the federal government dollars. And I think that's a very important thing to keep top of mind as we look at evaluating these programs and also seeing their effectiveness, not only for the state and the budgets that we manage here, but also in terms of their outcomes in supporting key programs around maternal health and others. So, Matt, is there anything you want to add to that one?
Yeah, I think I would just go back into thinking about the broader partnerships around this. And while it's hard to think of a better solution in terms of swiftness and efficacy of having Medicaid solve these thorny problems. The reality is that at the end of the day, Medicaid cannot and should not be the housing authority for the country. Medicaid cannot and should not be the food stabilization authority for the country. We are gonna need, whether it's SNAP or Section 8 or something else, to be able to come to the table in more sort of like a stone soup approach. Everybody has to put something in the broth to make this a meal that we can all eat. And I think there are probably things that we could do that are like thinking about 1115 waivers, if you will, that might bring in some other additional federal agencies, not just Medicaid. I mean, I remember Tommy Thompson when he went from being governor of Wisconsin to HHS secretary. One of the things he was super excited about was these kind of mega waivers to bring in all of the Health and Human Services funding sources to focus on the needs of the individual. And he just said, well, I got shot down by OMB. That's an issue. But that kind of thing could help bring some more flavor to that stone soup if we can get there.
I like it. Stone soup. I'm going to get hungry here soon as we approach lunchtime, Matt. So I think in that same vein, Rodney, this one's for you. What do you think are some of the most significant legislative or regulatory barriers that Medicaid's facing in addressing some of those health-related social needs, or even as we think about bringing this stone soup together? Talk to us a little bit about that.
You mean other than money and money and money and money and money and money and money? I mean, I don't know who's going to be in charge in the next administration. I don't know what their perspective is going to be. I don't think that the folks sitting over at OMB are going to take well to things that aren't very clearly intending to save money. Things that are spending money, waivers, etc. That's going to be a much more challenging hurdle to face. And so I think that the case made and Jamie started down that road. I mean, you've got to be able to make the case for the efficiency of what you're doing, leading to better outcomes. Matt, you went someplace and this is not a dig, it's just a statement here. 7-year windows to try to figure out whether or not something works here in this space is nobody's hearing that. Nobody's hearing it takes me 7 years to figure it out. The ROI's got to be in an incredibly short time window to prove that something is valuable enough to take the shot at doing so. Tremendous pressure there. But then on the other side, the legislative front, who knows what fresh hell is going to break loose on the Medicaid program in a reconciliation bill. I'm not willing to predict that right now, but I'm also not willing to tell you it ain't gonna happen.
Yeah. And if I can just add one thing, and then I'm sorry if I interrupted you, Jamie, but one simple thing that could be done, sort of put aside kind of budget reconciliation and hundreds of billions of dollars that might be at risk for another conversation. But it seems to me like one really simple thing that you could do to think about how does Medicaid like better empower the MCOs to help us solve these challenges is to rethink how like the medical loss ratio works. And to kind of, it was put in place years and years ago, concerns that, plans were putting too much money, not in healthcare, but in administration or overhead or profit or whatever. And that all made sense conceptually. But the way that the social drivers of health got determined in this they're not medical services. And so they kind of end up in the wrong part of the MLR equation. And it seems to be that it ought to be a relatively simple fix to say, no, these are, health, they're medical-ish, and just kind of shift it. And, it's not driving more overhead or profit or admin. It's driving better care. And it seems to me that ought to be a simple solution that could work, that might address some of this.
Jamie.
I think that's a really good point, Matt, actually. And you've seen states, following some guidance from CMS a few years ago around how to count kind of quality initiatives as medical expense under that MLR, really shift to policies which outline, the nature of that type of work and how you can count it as a medical expense. So this would be sort of the next step in that process, looking at some of our work around health-related social needs as medical expense. The other thing I was going to say, and Matt, you mentioned this earlier, on just a practical level, from an ROI standpoint, what you've seen states, that have received those 1115 approvals do in many cases, not all, in many cases, you've seen them really narrow the population that can obtain services like temporary housing or nutritional supports to those really high need, high acuity populations, so that they can actually develop that case using data around the ROI more quickly and easily, because there's just so much opportunity to ensure that those individuals, that we're eliminating some of their barriers around social services so that they can access clinical care. I know in Arizona, I think when we initially started talking about the housing benefit, the 1115 waiver, we were like, we're going to offer this to the entire population. But they have since, in a very thoughtful way, the state has really narrowed that population to really only individuals with a designation of serious mental illness, and in certain settings, and leaving those settings. And I think that's going to be really important in order for that turnaround to occur quickly, kind of to Rodney's point, so that we have those ROI cases available for policymakers.
And Sheila, if I could build on that a little bit, because I think it's important to think about that kind of like that thoughtful growth, like, going from that original concentric circle of everybody knows that this is a population you need to focus on, and everybody, part of it is being thoughtful, as Jamie said, about how do you actually show the ROI. But part of it is also, I think, the optics of it. And again, you go back 30 years ago, if Medicaid's providing SDOH services to people, that's clearly keeping them out of a nursing home, people can wrap their head around that and say, that makes perfect sense. If Medicaid is providing services to, somebody who's going to otherwise be in the emergency room 200 days a year, it makes sense. But if Medicaid kind of goes in the direction of saying, hey, we're doing housing for everybody, for 70 million people, to say nothing of the cost, the optics of that, I think, are really, really challenging. And it's like, wait a minute, taxpayers and people say, these are my tax dollars. Why are they going to provide, this whole universe of things when I myself am struggling with those same things? And so I think it's just, we need to be mindful of the optics of what we're doing as we start thinking about things that are not traditional cut and dry medical services. So it's a little bit of a political, but it's like a small p political.
Yeah. I understand where you're getting at with that. And I wanted to go into sort of that 7-year time horizon piece that we just talked about. So I think this is where managed care organizations also provide value, right? Because we can come to market, proof of concept, rapidly iterate. And we don't often think of Medicaid or sort of government programs as being these agile programs, if you will. So one way that we can kind of get to shortening those time horizons and proving that out is through these partnerships. And MCOs, I think, can play a key component in that, and helping shorten time horizons to not only help us understand outcomes, but also help the state understand what works and what doesn't. And I think that's a key way that we can participate And sort of on that note, Jamie, can you expand a little bit on the role that partners in community-based organizations play in addressing some of those needs, and maybe highlight any other specific strategies that you've seen have proven most effective?
Yeah, I mean, I'll restate it. I think managed care organizations and community-based organizations are really critical to the equation when it comes to addressing individuals' health-related social needs. In Arizona, our managed care partners were really essential to our work in the housing space. What we found out, so we did have some state funding to offer rental subsidies, and now the state is able to reimburse for temporary transitional housing. And while we were able to do that, what we knew is there was a lack of available affordable housing to place individuals in ultimately. So our managed care organizations came together under the umbrella of our community reinvestment expectation, and they decided to pool a portion of their reinvestment dollars to fund affordable housing around the state of Arizona. So that's a great example of how they helped us identify a piece of the or one of the problems in that sort of greater equation of housing. And they came together willingly on their own without any guidance from the state to invest in affordable housing, which was really important to our success ultimately with the rental subsidy work and transitional housing work. And so that's just a great example of how managed care organizations can be key partners. The other thing I would say in regard to community-based organizations, they're absolutely critical, obviously, to this equation. But one of the things on kind of a practical level that I think we need to acknowledge, and certainly states that have these 1115 approvals are acknowledging on the ground, is that many community-based organizations don't want to enroll with the Medicaid program. They don't want to contract with managed care organizations, and they certainly don't want to learn how to bill for services under a typical claiming protocol. So states have the 1115 approvals thinking about how to sort of support community-based organizations in a way that can allow them to effectively participate in the program. And some states have moved away from direct contracting with managed care organizations to actually establishing a third party, a liaison of sorts, that can act as a network aggregator, can also help CBOs in the billing process, and can just support them in the enrollment and credentialing process as well. Other states have decided to let managed care organizations contract with CBOs directly, but they've set up training and education protocols to make sure that CBOs can be successful. So I think, again, it's really important that we recognize that MCOs and CBOs have been doing this work for many, many years, decades, in fact, partnering, but that it's now incumbent upon us, if we want to be able to reimburse them for some of the services they've been offering as supplemental services, to your point earlier, Sheila, not supplanting available services and financing, that we provide the necessary support so they can be successful.
Yeah, and I guess I would just add to that as I think about it, like, could a state Medicaid program do all of this? Probably not really well. That's why they lean on managed care organizations to have the reach to do it. But even there, can a managed care organization really do everything that in this constantly evolving market? Perhaps not very well. So they need to reach out and engage those CBOs, to engage, community health workers and others. And I think about the example in Nevada right now, where they're out reprocuring their MCO contracts. And in a relative change, they sort of said, hey, the state has said, we need to focus on the frontier populations. The vast majority of people live like in Vegas and big cities, and there's some suburban and there's some rural, but there's also some frontier, which has really been neglected for a long time. And so the state has said, all right, MCOs, if you want to retain your business or if you want to get in, you're going to have to show us how you can make a difference out there where no one has paid attention in the frontier. And we're seeing the plans inside and outside coming and saying, all right, how do we get boots on the ground? How do we find, trusted voices out there in the hinterlands to really figure out who are these people? What do they need? How do we engage them? How do we improve their health? How do we improve the member experience? And it's all very exciting.
So on that note of, we had mentioned, right, we want to make sure that Medicaid is not supplanting, supporting, and bringing all of this together. What is that ideal cross-sectoral partnership between the state, between Medicaid agencies, federal agency? Matt, can you go into that a little bit?
Yeah, man, I think it has to kind of filter down. Like the state is going to take some kind of guidance from the federal government in terms of, what is the available budget and what are the federal parameters? What are the rules and the regs? And, obviously we talked a lot about, where the Biden administration was going with the managed care regs, with in lieu of services and everything else. How much of that is going to change? And how significantly is it going to change over the next, year, 4 years? Unclear yet. But the state is going to kind of filter down its expectations onto the plans. Say, hey, we expect the following from you if you want to be a successful partner to us in this endeavor of providing health to the millions of low-income beneficiaries in our state. And then the plans need to have some kind of like healthy cooperation competition between each other to sort of say, hey, we think we can do it a little bit better than you by trying this thing here. But at some point, trying this thing here is, if that's successful, then that gets adopted and that becomes kind of a new baseline. But again, then the plan has to push a lot of that outreach down to the CBO level to really get out and meaningfully engage with hard to reach populations.
Rodney, thoughts on this one?
I mean, and it better work. I mean, that's going to be the push. And a very painful thing, there's a presumption here that there are people who want this to be done at the federal level who are giving states permission. All right, so let's just steel ourselves the possibility that it's going to be a much colder conversation than have occurred over the last 4 years, where, again, there was once upon a time, I recall that if you showed up saying, hey, we'd like to make housing part of Medicaid, you'd gotten laughed at. And so we're seeing some expansions here in directions that, let's just see if the next folks are going to be as amenable to even the conversation we're having, unfortunately.
And so and that's a great point, and I thank you for continuing to bring that up. One aspect of that I think is going to be interesting to look at, and I don't know where this goes. I don't know what the answer is, but historically, Medicaid has been, it suffers like an understanding and an appreciation deficit. Because people don't, it's 56 different states and territories, it's hundreds of different health plans, and they're all named something different. And it's very, very easy for people to be on it and not realize it or think they're on something else, and to just sort of say, oh, but yeah, Medicaid, oh, well, that's that program for those people over there, to kind of otherize what Medicaid is and does. It's for poor people. I'm not poor. But I do think that, over the last couple of years, certainly through the pandemic, when Medicaid touched almost 100 million American lives at one point, there has been a slowly evolving kind of realization that Medicaid, and I'll use the words of our good friends at ACAP, Medicaid is us. Medicaid is not other. I'm on Medicaid, or my mom is, or my kids are, or my neighbors are, or what have you. And I wonder the extent to which, and this is what I don't know, the extent to which the incoming administration may lean into some of its evolving populist roots and acknowledge that a very, very large segment of its base, of its voting, members, are in fact on Medicaid and do want Medicaid to succeed and to continue to be a strong healthcare program providing them with things that they need, as opposed to, oh yeah, we can get a lot of money out of it because those people over there are going to get, program integrity, and that's fine. I don't know, but I think that's something to watch for.
Yeah, Matt, just really quickly, I hear the direction you're pushing, but I'm going to push you with an alternative version, which is if you want to talk to somebody about using Medicaid to provide housing and potentially nutritious foods and things like that, but then turn around and tell the same person that you can do that, but if you suggest that the same person receiving the benefit has to go to work, and if you make that suggestion, you're evil, that's not a good conversation. And that's the direction we're probably heading. And so that doesn't end up well for this one.
Jamie, anything to add to this one?
Know that I have anything to add. I was just going to give another example. In talking about sort of how that federal and state partners can work more closely or more productively, and how state entities can work more closely and productively with managed care organizations. I just wanted to give an example of something that was really effective in Arizona during the pandemic. We knew that a number of the people that were testing positive for COVID, because we were talking with our local shelters, in particular in the Phoenix metropolitan area, were homeless or at risk of homelessness. So we really worked at the state level to develop a cooperative agreement with the Homeless Management Information System, where we were able to obtain information about individuals that were residing in temporary shelter environments and pass that information on to managed care organizations so that they can intervene, especially when the vaccine was available, and make sure that individuals in those environments were vaccinated for COVID. And so that's just I think, a nice example of how that sort of cooperation can be really helpful at the sort of state and local level, working in partnership with managed care organizations that we're doing that direct outreach. But that level of cooperation, kind of going back to Matt's earlier point, needs to be modeled at the federal level. It needs to start at the top, so that we can be really successful at the state level and then working with our local partners. And I think that's where the real opportunity is, so that we do ensure, in fact, that the services we're offering are supplemental in nature and they're not supplanting existing services, which, by the way, with the 1115 waivers that were approved, there was some very clear language around ensuring that we weren't supplanting existing services and measuring that and looking at that very closely. But I do think there's opportunity at the federal level to, work more closely on an interagency basis to ensure that we're taking advantage of the resources that the various agencies have to offer.
Yeah. We've talked a little bit about COVID-19 pandemic, and hard to believe that was only just a few years ago, as we kind of come into what is a more quote unquote normal state of things. But COVID-19 really exacerbated a lot of the health disparities we've seen in the system, particularly among Medicaid enrollees, other low-income people. What role do we believe that Medicaid here should play in addressing those health disparities and continuing to advance health equity? Jamie, do you want to start with that one?
Sure. As we know, nearly 80 million Americans are served by the Medicaid and Children's Health Insurance Program. So that's a large portion of this country's population, and over half of the individuals on Medicaid are people of color. So Medicaid does play a critical role in eliminating the disparities that exist. And I think it's just really important that Medicaid programs commit to identifying the barriers to care that exist for marginalized populations and addressing those barriers proactively. But as we've discussed today, I think it's very evident that Medicaid programs have been doing that work, are really committed to it, are really committed to kind of breaking down the data to ensure that they're examining how various populations are accessing care and trying to address kind of the upstream barriers to accessing care. And that's what our work around health-related social needs really does. It tells us that transportation, education, nutritional nutritional food insecurity and housing stability are key to ensuring that individuals access appropriate preventive care and don't access higher cost care in the emergency room or the urgent care setting. And so, I would argue that states are doing that important work. They have been, again, long before we started talking about 1115 waiver approvals. So it's just important that we continue to really engage with the data and work hand in hand with managed care organizations and community-based organizations to eliminate those barriers to care, so that folks can live independent, successful, productive lives, and hopefully at some point roll off the program and obtain coverage through other sources.
Yeah, and I would build on that I'm glad that Jamie is trying to recognize and celebrate what Medicaid has done and is currently doing. That we also need to be thoughtful about how we approach dealing with some of those inequities and disparities. And I think we probably can't pretend like there aren't going to be like broader political dynamics around this, even though some of the disparities are very, very real. But so while there are like very, very clear and very, very problematic racial and ethnic disparities, take, for example, the maternal mortality rates for African American women. It's appalling and it needs to be addressed. But there are also, quite frankly, a lot of other disparities that exist in our country and in the Medicaid program and in the healthcare system. And I can think about like West Virginia, where if you look at the healthcare outcomes of folks in urban areas as opposed to like in the Appalachian region, you will see disparities that are just as wide and just as significant as in other states around racial and ethnic lines. So there's a lot of ways that that states or MCOs or everybody else can address the parts of the disparity, spectrum that are going to be most meaningful in that area. And I think it's important to do that thoughtfully and to do that in a way that that you maintain the buy-in of the policymakers, of the providers, and of everybody else in it. And it's difficult, but it's really, really important.
Yeah, we are headed into our last 5 minutes of this webinar with our final setup question for the next year and a few beyond. Given the change in administration, we've talked a little bit about this already, Rodney, and you've been able to comment throughout. What else do we see here in terms of Medicaid's role and changes and how this is going to be evolving over the next 4 years? And how should we be thinking about and I've had this conversation in other venues, how we talk about this program and the language that we use to be able to ensure that we are, expressing the value of these things.
With absolutely respect, not like what Jamie and Matt just did. And now let me give you a few more words. All right. If you want to talk about equity, if you want to talk about disparities, you can talk about that. But I think that those words have, over the last few years, started to be used in ways that the incoming majority does not take well to. Not my fault. Okay, and that it has become radioactive is not, I can't sit here and justify it. I'm just telling you it is. So you might think more instead of producing better outcomes, producing healthier outcomes, making America healthy again. See what I did there? All right. But you know what I didn't say? Didn't talk about disparities and I didn't talk about equity, but I mean the same thing. So the trick is going to be trying to get where you were already going, but choosing different ways to describe the route.
Yeah, I hear loud and clear. Knowing your audience, very key to this discussion.
Reading the room.
So in reading this room, I am so grateful to all of you for the various perspectives. I think it really was, a great discussion, hearing about sort of where we've come from, where we're going, and the things that we really need to keep top of mind to ensure that a program like this that does support a lot of the underserved communities and unmet needs continues to do what it is intended to do. So thank you all so much for your participation in this. Thank you, Rodney, Matt, and Jamie, for your perspectives. Incredible insights here. I would also like to thank everybody who's registered for and attended today's event. Have a wonderful day. Maybe don't have stone soup, or do have stone soup. And we will hope to see you all later on a subsequent webinar. Thank you so much.
Thanks so much.